Guest on the show today from Henry Ford Jackson Hospital, orthopedic surgeon, Dr. Derek Semaan. Welcome to the show.
Thank you for having me.
Yeah, and welcome to Jackson.
Thank you. It's been a little over a year now. I've enjoyed my time being here so far.
Awesome. Well, knowing the population, I have no doubt that you've been extremely busy since you arrived.
Yep. Whether I liked it or not, I got busy really fast, and it's been a fun ride so far.
So, joint replacement. That's I know the meat of your practice. What joints do you specialize in?
So I spent 5 years training in all aspects of orthopedic surgery, and then I spent 1 year after that focusing on hip and knee replacements. Mm-hmm. That's first-time surgeries and also redo surgeries when things don't go right the first time or over time as the joints have failed.
Oh wow, I've had hip replacements, so it could go bad.
Absolutely. There's a lot of things that can go wrong. I mean, I always tell people it's about a 1% chance of having a complication, but even with that immediate complication risk, you have over time to wearing through the joint, depending on how much demand you're placing on it.
And if people get a joint replacement young in life, there's a lifespan for a replacement joint, isn't there?
Absolutely. You know, they used to say 10 to 15 years, but our data is not really updated at this point. We have new modern plastic that we're using that really has better wear properties than it used to have, so it can last up to 20, 25 years. A lot of it depends on your activity level, weight, a lot of other factors.
Which is harder from a surgeon standpoint, hip replacement or knee replacement?
Definitely a hip replacement. Okay. Yeah, it's a lot of pounding and demand on the shoulders.
Yeah. Do you ever use your knee while you're doing surgery to gain leverage?
I use my thigh, I use my knee, I use a combination of things. Some people use leg holders for knee replacements. I don't. So sometimes I do have the patient's leg resting on my thigh, and so I feel that at the end of the day. But it's just how I trained and how I like to do things.
I was looking at your background, and it looks like you spent some time as a special education teacher after you got your undergraduate degree.
Yeah, so my background is definitely anything other than the normal route to medical school. I started out wanting to be a tax attorney, so I studied economics and accounting in undergrad. When I got to my senior year, I realized I'd probably be miserable in life as a tax attorney. Mm-hmm. So while other people were getting ready to graduate, I was taking the basic science classes. Even though I did graduate on time, I had to take some time afterwards to do that. After I finished all the science classes, I still wasn't ready for medical school. So I applied to a program called Teach for America, where you're placed in a low-income area and you teach. My background being math and science, I thought that's where they placed me, but they placed me in special education. I had no idea what it would be like at all, but I embraced it. And you know, I ended up teaching for 3 years, an extra year. It's a 2-year commitment. I always told people during medical school was a breeze in comparison to teaching. I have the utmost respect for teachers and what they do on a day-to-day basis.
Yeah, especially special education.
Absolutely. It's one thing having to take care of yourself through med school and worry about yourself. It's another thing having to worry about 30 students in a classroom.
So you didn't take any pre-med as an undergrad, so you had a longer route to being a surgeon.
I did, yeah. I had to do 2 years afterwards. And you know, with medical school now, it's so difficult to get into. You have to have the research and all the background. So I was really starting from ground zero with everything. But I wouldn't take any of it back because I think I was a lot more prepared for medical school than a lot of my colleagues.
So once you decided you wanted to be a doctor, how did you narrow into the specialty of orthopedics?
You know, growing up, I always liked working with my hands. Particularly, I have an interest in woodworking. So when I got to medical school and I rotated through all the various subspecialties, I was naturally drawn to orthopedics. A lot of the principles that we use in the operating room are the ones I use at home in my garage, right? I tell patients, I say, if you walk into my garage, it's a lot like my operating room. I just have cleaner tools in the operating room. But again, in medicine, there's 2 different types of people. There's a primary care doctor and their various subspecialties, and then you have surgeons. I'm very surgeon-minded. I like to see a problem, and then I like to offer a solution, not necessarily watch it over time.
Well, people come to me for medical advice, surprisingly. But friends, they want to know, because since I had replacement, the question they ask, you know, they're complaining about their knee or their hip or their shoulder, and I think the number one question is, well, how do you know when it's time to actually have the surgery? And I know you get that a lot too.
Absolutely, and that's a great question. I always tell patients, I'll never tell you that you're ready for a surgery. But what I do is I listen to you. I want to hear, are you having more bad days than good days? Are you are you limiting what you want to do because of the pain? Have you tried other alternative non-surgical options? When you've done all that and your quality of life is limited and you're telling me that you're struggling on a day-to-day basis, I think that's the point that we talk about surgery. At the end of the day, a hip or a knee replacement is an elective surgery. It's not heart or brain surgery. We don't have to rush you to the operating room. It's a quality of life surgery. So I always like the patients kind of tell me when they're ready, as opposed to me, telling them that they're ultimately ready.
That's the right answer. You passed.
Thank you. Thanks.
I think one hesitation people have to going to see you is that, oh, well, you're a surgeon, you're going to recommend surgery. But that's not always the case.
Definitely not. I tell people I'm a surgeon. Don't get me wrong. I love a scalpel and I love to operate, but that's the last resort. When you come to me, it's very rare that I'm going to offer you surgery on the first visit. I always start with the least invasive, talking about how are you modifying your activities, taking anti-inflammatories like ibuprofen or Motrin, using a cane or a walker to get around. When those fail, we talk about injections into the hip or the knee, whether we're talking about steroid or gel injections. When all else has failed and we've tried everything, and that's the point we talk about surgery. So.
Are there certain things people do in living their life that will make them more susceptible to joint damage that requires some sort of intervention?
There's no data to say that, the more demand you put on your joints, certainly the more wear you're going to put on them, right? Ultimately, osteoarthritis is genetics. So you can thank your parents or your grandparents who had knee or hip replacements for giving you those genes passed down. But I would never tell somebody to limit what they're doing because they're afraid of requiring a joint replacement, right? If you're enjoying playing basketball at the age of 40, 45, don't stop playing basketball because your knee's hurting a little bit. There's alternative methods for you to get through that. And it's more about continuing to enjoy what you do.
So there are some things that you might suggest to someone before they're actually ready for surgery.
Absolutely, yeah.
And then once someone has the surgery, there's a lot of, I think, responsibility on the part of the patient to make sure the surgery is successful. It's not, here you go, have a nice day. There's a lot of rehab that goes on.
Absolutely, and you can attest to this,
Yeah.
especially more so for hip than knees, but certainly what I do in the operating room, I do everything I'm trained to do in putting in a joint. I don't say I'm perfect, but I do as best as I can in doing it and give somebody a great joint. However, I pass the baton on to the patient, right? If I just do a knee replacement and the patient goes home, doesn't participate in therapy, doesn't take their pain medicine, they're going to have a bad outcome. They're going to have a stiff joint. It's not going to work as well as it's intended. So it's really a partnership. I can do everything in my power to give you a good functioning joint, but as the patient, you ultimately have to take ownership over it.
Do you know this orthopedic surgery joke? I get pain in the joints. Stop going to the joints. That's right. So the misperceptions or misconceptions about joint surgery, what are some of the things you hear?
Yeah, so it wasn't uncommon for even 5-10 years ago for a patient to come into the hospital, require a hip or knee replacement, and stay for a week or longer. So people still think that. They think they have to go to a rehab facility. As I alluded to earlier, when you're having a joint done, it's an elective surgery. So you should be a healthy patient or otherwise optimized. What we realize as joint patients is we're bringing in these healthy patients into the hospital with unhealthy patients who are admitted. And it's just a recipe for disaster. These patients are getting blood clots, pneumonia, infections. So what we've really focused on are rapid recovery protocols. So my patients are getting up the day of surgery, working with physical therapy, and I'd say 70 to 80% are leaving the same day. We consider this an outpatient surgery now. So,
yeah, in and out.
Yep.
And I had what my trainer called prehab. He got me ready ahead of time so that the surgery would go a lot more better, and I'm convinced it did.
Sure.
What's your greatest satisfaction or makes you most excited about being an orthopedic surgeon?
So this kind of leads me back to why I ultimately chose orthopedic surgery. A patient comes in for their preoperative visit. They're in debilitating pain, using a walker, not leaving the house, can't even go grocery shopping as a result of their pain. After surgery, I see them back at their 6-week mark. I used to see patients at 2 weeks. I realized that was a mistake. That's too soon. I pushed it out to 6 weeks. Because at that point, they're already done the rehab. They're about 70 to 80% recovered. Majority of the time, not using anything, a cane or a walker, not taking pain medicine, and they're just so thankful to have their life back. And that's what brings me the ultimate joy in being an orthopedic surgeon.
Yeah, and I think you're right. It takes a few weeks for the patient to fully appreciate what they just went through.
Yeah, I tell people I take away your arthritis pain, but I give you surgical pain. The good news is the surgical pain only lasts so long, and then you're hopefully pain-free.
Now, the surgery you do, you can't, there's no robotics involved, and I can't picture robotics being able to do what you do.
So that's actually not true. There are robotics, and we have a robot at the hospital. The problem is we don't use it. I'm trained in hip and knee replacements. The robot is good for surgeons who don't perform a lot of these procedures and performing it precisely. In my mind, it's clunky bringing the robot in. It takes up space, and it doesn't add much to the surgery. And in fact, I think it takes away from the surgery an infection risk and adding surgical time. Patients often come in, I think it's using as a marketing ploy to say, oh, we have robotics here. But I tell them, a robot's right here. What I need to see is right in my head, and what I know and kind of practice. I don't need a robot to do what I do.
Yeah, and obviously there are certain things with robotics that you can't do with your hands.
No, I don't think it's hard to. Yeah, it's hard to reproduce what you can do, with a human tactile sensation.
All right, somebody has joint pain, or there's an issue. Do they need to see their primary physician first before they see you?
Oftentimes, because of insurance purposes, and it's just the insurance purpose, they have to get a referral to me. But there's a lot of times I see patients without, they're self-referred.
Cool.
Yeah.
Well, we appreciate you coming in today. Welcome to Jackson. And if somebody has a question, they just call your office, and you're right here.
Yep, right in town, Jackson.
All right.
East Michigan.
Thank you,
Thank you very much.
Dr. Derek Semaan, orthopedic surgeon at Henry Ford Jackson Hospital.